Hi, welcome to Johnston Health Talk. I'm Liz Thurston with Johnston Health. Today our show is a wonderful show. We're talking with Dr. Willis Wu and Dr. Christian Gring from NC Heart and Vascular. And we're going to be talking about the structural heart program with NC Heart and Vascular and all the different procedures that we're doing now in heart care. So welcome to the show today.
Thank you, Liz. Thank you very much.
So the structural heart program is, tell us a little bit about what that means. What is that?
So, you know, when we tell patients about the heart, it's a very complex organ, but we like to make the analogy that the heart is like a house. And you have the basic structural foundation, which includes the walls, which in our case are the chambers of the heart. There are 2 top chambers and 2 bottom chambers. The heart also has a plumbing system, which is the coronary arteries, and there's also an electrical system, which is akin to the electrical system in a house. And traditionally speaking, when people think of heart disease, they think about the blood vessels when you talk about heart blockages and coronary artery disease and people having heart attacks. But the newest arena is having problems with the valves, which are basically the doors of the heart that allows blood to travel in one direction from one heart chamber to the next. And we have different techniques where we can fix heart valves and fix the defects along the heart valves and the walls of the heart using non-invasive or minimally invasive techniques.
Okay, so when we normally think about heart disease, we think about open heart surgery and kind of everything that goes with that. And so with the structural heart program, we don't have to do open heart surgery anymore. That's correct?
That is correct. So historically, open heart surgery has been the treatment of choice for many of these valve problems. And it still is a very good option for many of our patients. But as patients start living older, living longer, and really having more comorbidities, open heart surgery becomes a difficult procedure for many of our folks to get through. And over the past 5 years, really, a number of technologies have come up to allow us to treat these fairly difficult valve problems using non-operative techniques so that frequently patients aren't even put to sleep anymore. It's done under conscious sedation, which is basically light sedation. They're still breathing on their own. They're not put on any type of bypass, not put on a ventilator for many of these procedures. And it's a much gentler way to remedy some of these problems.
So with these type of procedures, would we only consider these type of procedures for patients that can't go under an open heart surgery, or is it specific to valve?
Well, I think it's an evolving field. I mean, with the aortic valve disease, which we'll talk about here in a little bit, initially when that technology was approved a number of years ago, it was explicitly approved only for patients who could not tolerate surgery. But it's been such a remarkably successful technology that it went from people who are frankly inoperable to people that were considered high risk for surgery. And last month they released data on intermediate risk patients, patients who historically really haven't had difficulty getting through surgery. And the newer technology has fared as well as surgery in these patients. So it's really a sea change in the way that we think about treating valve disease. That this technology really seems to be replacing surgery in intermediate and higher risk patients. We're particularly excited because it's now being examined in lower risk patients, people that are over the age of 65 but really don't have a whole lot in the way of other medical problems who, you know, again, historically would be referred for open heart surgery. But they're now studying this type of valve, and we as a program are involved in that trial looking at lower risk patients. And we expect the valve the structural heart valve, the minimally invasive valve, or the catheter-based valve to do very well compared to surgery.
Okay. And so you have a team of doctors that work together to evaluate the patient before these procedures are done. And what are the different specialties within your practice?
That's a great question, Liz. And this highlights one of the newer philosophies in cardiovascular care these days. And we take a really team-based approach. And so we have 2 cardiac surgeons on our team. Those are the doctors that traditionally would do the open heart surgeries. We have 3 interventional cardiologists on the team, and these are doctors who traditionally did coronary stenting and things like that. We have 2 cardiac imagers, of which Dr. Gring is one of them, and their focus is mostly on advanced cardiac imaging through transesophageal echo and cardiac CT scans. And we have cardiac anesthesiologists who are dedicated to the cath lab hybrid OR, and they monitor the patient's vital signs and administer this light anesthesia that Dr. Gring was referring to. And that's just within the construct of the procedure room itself. The heart valve team is also comprised of our fantastic nurse practitioner, Brianna G., who helps see consults and organizes the clinic, and our clinic coordinator, Michelle Woody, and Stephanie Belvin, who is her administrative assistant. So it really is a large team, and it just highlights the ability to work well together through a multidisciplinary approach.
So we hadn't talked about what these procedures are called. There's 3 specifically we're going to talk about. Tell me a little bit about them. So the first one being the TAVR.
TAVR, which is a transcatheter aortic valve replacement. And that's a procedure which became approved about 3.5 to 4 years ago. And again, that's the procedure looking at the aortic valve, which is a valve that leads out of the heart. It's the most common acquired valve that goes bad in patients. So it's very common as patients get older that valve becomes very stiff, very calcified, and stops opening well. So when the heart tries to pump, it tries to pump blood out this opening, and it becomes increasingly narrowed. It puts a lot of strain in the heart, and patients start developing symptoms like fatigue and shortness of breath and lightheadedness and dizziness, and ultimately frank chest pain, heart failure, and ultimately death. I mean, the prognosis of symptomatic aortic valve disease is really quite poor. So without intervening on the valve, patients do very poorly, and there's no medical therapy for it. So up until 4 or 5 years ago, it was open heart surgery or really hospice, really palliative care for these patients. So there really wasn't a good medical option. So the transcatheter valve is something that we were very excited to get involved with a number of years ago. And so that's that's a procedure where we try to get a valve in through a catheter or through a tube. And the technology has really come quite a ways over the past couple of years through several iterations, so that now the tube that we use is probably about the size of your pinky. I mean, it's about a 6 or 7 millimeter wide tube, and for most patients, we can get in through the leg artery. So just similar to the way a heart catheterization is done, we're able to put a fairly, it's a long tube, but we can get in through the artery in the leg and thread the valve up to the heart, from the leg arteries up to the aorta, up to the heart, and then expand the valve using a balloon.
Do we want to show video of that? You want to see?
That would be fantastic, because that's worth much better than my description. Dr. Wu, do you want to narrate this one?
So this is a case we did just a little while ago, and this picture you see here is a picture of the artery in the leg. And as Dr. Gring alluded to, traditionally the patient would have to go to the operating room and have their breastbone cut open and the heart exposed. But now we try to go in through the leg arteries if possible, because it's less invasive. And so we take a picture to make sure we know where we are, and we place our equipment into the body. You can see here the valve is getting prepared, and we will deliver it through that, what we call a sheath, which is basically a large tube in the artery. To ensure that the artery doesn't bleed afterwards, we do put some stitches in beforehand, and we can do this again without having to open the leg artery or expose it, but we do it in what we call a percutaneous fashion, which means through the skin. We do have to prepare the initial incision site by dilating a little bit, but again, you can see here that there's several people in the room, and even though it is a lot less invasive, it still does require a few number of people. But I think the important thing about the team approach is that we can offer the patients the best therapy. It's not one doctor thinking surgery is better, one doctor thinking the TAVR procedure is better. When we have all of our team members in the room, we have surgeons and cardiologists coming together and saying, what's the best for this patient? And sometimes the answer is surgery, and so we do still operate a good amount, but many times this new TAVR procedure is the way to go. And you can see in the bottom right-hand corner, Dr. Gring has obtained a wonderful 3D image of the heart valve, so we can accurately place the valve. Here's a computer animation of what we're doing. You can see that calcified valve in the middle. It literally is hard like a rock, and we do have to open it with a balloon, what we call a valvuloplasty, before the valve can even get across. It's a very sterile procedure, as you can imagine, and the valve comes fully opened, and in order for it to fit in the leg artery, we have to prepare it first, and then we have to compress it onto our delivery catheter system. So this is an illustration of the other team members in the cath lab who are preparing the valve, and we have to flush the delivery system so as not to introduce any air during the procedure, because that can be dangerous sometimes. But the technology is amazing, where we started with fairly large equipment, and it has gone smaller and smaller, which allows us to deliver the valve in patients who have more complex blockages in their legs, and so the technology is more available to people. And the risk of vascular complications has reduced a lot as the equipment has gotten a lot smaller.
It's amazing how small, I mean, that it comes, you have to crimp it first before you're entering the body. And just seeing that procedure and, making your way up through the body into the heart and placing that is amazing. And I know you have to be very accurate at placing that, and just having that team together, I know, is very helpful to the patient and to your team.
Yeah, not one position is any more or less important, and that's the beautiful thing about the procedure as well, is every person there and every position that they are in and every job that they're doing, without each one of those people, the procedure would not go well and would not go smoothly. So it works really well.
So the patients get evaluated through multiple visits to the valve clinic, and so they see surgeons independently, they see cardiologists independently, and then from an imaging side, which I am involved in, we do CAT scans of everybody's heart, we do CAT scans of everybody's legs, and that helps us really on a millimeter by millimeter basis evaluate whether we can get a valve in through their leg. And so we know very well what we're getting into on these patients before we go, and they're very well evaluated, very well worked up, and they meet multiple people on the team. And so it really is a great strategy to make sure that patients are getting really the best care that we can deliver, and that they've been looked at from multiple different angles to figure out what the right therapy is for them.
Yeah, and if you don't have to have open heart surgery and you can take care of the problem this way, I think that the patients are feeling this is the better choice for them. You guys have already evaluated that and determined that, and they're confident when they're going in.
Liz, it's amazing that you see the patients during the procedure, and our first case is at 7:30, and by noon, oftentimes the patients are sitting up in their bed eating lunch and talking to their family. One patient was reading a newspaper by noon.
Oh, wow.
And usually the patients go home 2 to 3 days after the procedure. And so it's a remarkable evolution of what has come in the last 10 or 20 years in aortic valve treatment.
And it'll be nice in the future to see if we don't have to do any open heart surgery and everything can be done this way.
Well, I think it's a very realistic possibility. I mean, the valve performance has been, especially for the aortic valves, has really been phenomenal. It really just changed the way that we think about aortic valve disease. Not just looking at patients that historically have been considered too sick to operate on, but looking now at patients that really aren't that complicated from a heart standpoint. Mm-hmm. These are patients that would stay in the hospital 5, 6, 7 days after valve surgery. These lower risk, healthier patients go home 2 to 3 days afterwards. They don't have nearly as much pain. There's not the sternotomy pain. There's not the complications from anesthesia. There's not complications from lung infections because people have been intubated and haven't been breathing well on their own. I mean, the recovery, the ability to get mobilized, the ability to go home, it really is phenomenal. I mean, it really is. It's probably the biggest change in cardiology over the past 10 years.
And so tell us about these other procedures.
So there's another valve in close proximity to the aortic valve called the mitral valve. And the mitral valve allows blood flow to go from the top left chamber to the bottom left chamber. And what can happen over time is that the leaflets don't come together as well. And once the valve comes together, it's not supposed to allow blood to go backwards. But sometimes it does, and that's called regurgitation. And sometimes patients have severe mitral regurgitation where instead of exiting the heart, the blood is being pushed backwards into the lungs. And patients can develop the same sort of symptoms as with aortic valve disease, with shortness of breath, congestive heart failure type symptoms, swelling in the legs, and just overall fatigue. So again, just like the aortic valve, traditionally the therapy was an open heart surgery, but now we have a new device called a MitraClip that allows us to treat patients without opening the chest and going through the groins again.
So here it looks like we have an animation of the MitraClip procedure, and this is a procedure that's done again through the leg, but it's done through the vein in the leg rather than the artery, which we use for the aortic valve. And the catheter is advanced up through the vein in the leg up to the right chamber of the heart, and we're able to cross between the right upper and the left upper chamber of the heart with the device, and then look down on top of the mitral valve. and then able to put the clip in position. And what we're doing is we're doing all this procedure under ultrasound or echo guidance, looking for the area that we think is the most dysfunctional or responsible for the leak. And so we're able to fairly precisely place the clip in the segment of the valve that's leaking, and then bring the clip up and grasp the dysfunctional part of the valve and clip it essentially, which usually resolves a great deal of the leak. These patients are too sick to undergo surgery. Mitral valve repair surgery is a phenomenal procedure. It's got a very high success rate, and patients generally do very well with it. And so this really is a procedure for patients that, for multiple reasons, aren't great surgical candidates. But it's been very effective at reducing the leak from a severe level to a mild or maybe mild to moderate level, and that's usually good enough to allow patients to feel better. It resolves a lot of the shortness of breath and fatigue symptoms that they have.
That was going to be one of my questions when watching the video. I saw there was one clip, but you still had some areas where there may have been some leakage. So do you ever have to go in and do multiple clips, or it's usually just one takes care of solving the problem there?
I'd say in the cases that we've done, probably 40% of them, 40–50% of them have required 2 clips. And that's just, you know, every patient's different. And the last patient we did about a week or so ago just required 1 clip. We went in there, clipped the leaflets, it looked great, and we got out. But, you know, oftentimes, depending on how broad the jet is going to determine how many clips we have to put in. So you can put in as many clips as the valve will allow, as long as it doesn't prevent the valve from opening. And that's what we worry about if you put in too many clips. But again, Dr. Gring and Dr. Jallis, our echocardiographers, are checking very carefully to make sure that there still is adequate flow through the valve.
So now, will your body then just kind of absorb that clip, or does it have to be replaced every so often? How does that work?
That's a great question. So the clip itself looks like a clothespin, but it is covered with a polyester coating that promotes a phenomenon called endothelialization. And what that really means is that it promotes tissue growth within it. So what I tell patients is, you know, for example, if you get a splinter in your finger and you didn't take it out, your body will form a little scar tissue around it to try to seal it off. The body does a similar thing in the mitral valve position, where when we leave the clip in there, the normal response of the body is to form one layer of tissue surrounding the clip, and it thereby kind of incorporates it as part of the native valve itself. And that's a process that we expect, and it helps prevent blood clot formation on the clip long term, and it helps to prevent future infections on the clip. And so that is a process that the body undergoes naturally.
Okay, well, that's good to know. And then the third device that I'd like you guys to talk about is called the Watchman device. Tell us a little bit about that.
Well, the Watchman device has been developed out of really the epidemic of atrial fibrillation, which is an abnormal heart rhythm which becomes increasingly more common as patients get older. So age and high blood pressure in particular are probably the 2 biggest risk factors. And historically, those patients have been treated with anticoagulation. They still are, so Coumadin or some of the newer agents, because atrial fibrillation not only can make people feel bad, but it also can cause blood clots to form in the upper chamber of the heart. Those clots can break loose and lead to stroke. The problem with blood thinners is that not every patient is a good candidate for blood thinners because they can cause bleeding. And so if patients are at high risk for bleeding, we still want to have the option to protect them from stroke, but we don't want to put them at risk for bleeding. And so what the Watchman does is it occludes or plugs the left atrial appendage, which is a little sac that kind of hangs off the left upper chamber of the heart where the majority of clots form, and basically seals that off so that blood clots can't form there. And Dr. Wu, is an expert in this, so why don't you narrate this one?
So it's similar technique to the MitraClip, where we go in through the vein of the leg, and we actually, to get to either the mitral valve or this appendage, we have to poke a hole through one of the walls of the heart to get our equipment there. A lot of times that hole will seal off by itself and does not usually cause a problem. So we can put this tube and a catheter into this left atrial appendage, and as you can see, the left atrial appendage is actually quite a complex structure. There's different shapes to it. One's called the chicken wing for obvious reasons. One looks like broccoli, and the most common shape is called a windsock, where it just looks like a big sock hanging in the breeze. But you know, very carefully we advance our equipment into this atrial appendage. Very similar to TAVR, we size the device very precisely before the patient gets there, using transesophageal echo and perhaps 3D CAT scan imaging. Because especially with this Watchman, this appendage comes in various sizes, and in order to successfully plug it, you have to accurately pick the right size, because if you pick a device that's too big, it may pop out. If you pick a device that's too small and it may not fully plug the entirety of the structure, and then little blood clots can come around it. It's approximately the same size as our TAVR valves. And essentially the device is a big umbrella that's supported on a metal framework, and we put the equipment into the atrial appendage, and then we deploy this device that has a polyester framework on it. And we take a couple injections to make sure we're adequately plugging it. And once we have determined that it's in the right spot and it's not going to move, then we release the device. And similar to the MitraClip, we expect this device to undergo this process called endothelialization, which means we expect a layer of tissue to grow around it. And essentially it incorporates it as part of the body. And we have seen in animal studies, when you look at it, you can almost barely see the device because it's covered in a layer of tissue.
Okay. It's amazing, it really is. And I know that everybody that's watching is just amazed at what technology has brought us, and having the experts here in our community and taking care of us. And now you do these procedures at Rex Healthcare, is that correct?
We do.
Okay. And so, but you guys are both coming to Johnston County as well as Knightdale, and you're in Wake County as well. And so patients can see you pretty much anywhere, which is great.
Yeah, I think it's one of the strengths of working in a group like North Carolina Heart and Vascular is that we just have multiple offices in really multiple communities. And I think that really gives us an opportunity to meet patients where they are, prevent people from having to drive too far from their home. And I'm down in Clayton a couple days a week, and up in Knightdale a day a week, and Dr. Wu's all over the place as well. And it's just, there's so much great technology here and so much great really progress in terms of treating fairly common and fairly complex heart disease. But it's becoming increasingly easy for patients to tolerate these procedures and really benefit from them. So it's just a very exciting area of cardiology.
Now, do patients come to you from a referral from their primary care? Are they calling, self-referring? How do you normally find your patients?
Well, I think it's a little bit of everything. I think that I think most of the patients come from other cardiologists because they're being evaluated for either valve disease or heart rhythm problems, but we still see patients that come in from their primary care doctors who have sent their patients for echoes and recognize that there's a valve problem, or to be honest, primary care people see a lot of these problems, and they're really the front line of picking up valve disease and murmurs and irregular heart rhythms. So we see a fair number of patients that way as well. We probably see fewer patients that are directly referred in. I think some of that's just the evolution of the technology, that it's new enough that it hasn't been, I think, disseminated out so that everyone's aware of it. But it's part of the purpose of being here today. Actually, is to really try to inform folks that there are these great, really technologies, great treatments available.
And I think we're going to see something different with the Watchman device, because there's so many patients. There's millions of people with atrial fibrillation, and a lot of them cannot tolerate blood thinners. And we'd say with the Watchman device that the #1 therapy to prevent strokes really is using blood thinners, whether it be the traditional Coumadin medicine or these newer agents. The Watchman device is an alternative for patients who have a reasonable reason or rationale not to be on these blood thinners. So a lot of primary care doctors run their own Coumadin clinics. So we think that, whereas I'd say in our experience the valve issues and the patients with valve disease have come a little bit more predominantly from the other cardiologists. But I think with this Watchman device, certainly there's thousands of patients being taken care of by their primary care doctors and primary care providers that, in my clinic alone yesterday, I saw 3 people who have atrial fibrillation and who were on a blood thinner or had been on a blood thinner in the past and had either a spontaneous gastrointestinal bleed or a small intracranial bleed, or just had enough nosebleeds that was requiring them to go to the emergency department several times a year. And so when we put patients on blood thinners to prevent stroke, it's a little bit of a trade-off where we are trying to prevent a life-threatening or debilitating stroke in somebody, but the therapy is a little bit dangerous themselves. These blood thinners have an annual bleeding risk of about 3 to 4%. So whereas they are the best treatment strategy we have for stroke prevention, they certainly are not completely benign either.
Mm-hmm. Yeah, and I think it's important to stress to patients to do their annual exams. If they're having problems, to go see their doctor, go to the emergency department, and if they're having some heart pain or any kind of symptoms that we try to educate everybody so often to follow up on that. And if that means calling your office directly to get that care that they need, then certainly they can call you directly. And I definitely want to share that information. You can find more information on ncheartandvascular.com, as well as calling 919-784-1321 and ask for Stephanie to make those appointments. Just a few more minutes that we have. What would a patient expect for follow-up once they've had these procedures? Is there several appointments to follow?
There are mandated appointments that people have to keep, and mostly because this technology is so new that Medicare or CMS has mandated that we basically keep a registry of patients so we can track how they do. And really it's just an outcomes sort of database, so it's not terribly intrusive. So we have patients that go home from the hospital, and within 2 weeks they'll come back to the clinic for a post-operative check. And then we see them at 1 month after the procedure. We usually see them 6 months after a procedure and a year after a procedure.
Okay.
So there are a couple follow-ups. What we also try to do is, because a lot of these patients have cardiologists in their area, be it down in Johnston County or the surrounding counties, Wilson or Goldsboro, we try to really include their primary doctors and their cardiologists in those communities as well, and so they're really followed by us, but also by their local doctors as well.
And we find that they really like that, because one thing that initially they may have been concerned about is, oh, well, we love seeing Dr. Atkinson or Dr. Janice, and we don't want to go see those or have the procedure done in Raleigh. But they soon realize that, again, it's not just teamwork within our team itself, but within the construct of our own group. And so they're so happy to see us after the procedure's done, but then know that long term they're still going to follow with their normal doctors in their hometowns.
Yes, and I think that's important that they know that the team is there to take care of them. And thank you so much for joining us today, Dr. Wu and Dr. Gring.
Great, thank you
very
much.
Thank you.
NC Heart and Vascular, and again, I'll share that information, ncheartandvascular.com. The phone number is 919-784-1321. Thank you so much for joining us today, and please join us on our next show for Johnston Health Talk. Thank you.